to do in this session, which is my last session for this RML course. And before I begin this, I would really like to thank Gaurav Raj sir for giving me this opportunity. I would have loved to be physically there and interact more, but unfortunately, that is not possible. So I just hope you guys have heard things and you have listened them well. If you have any doubts, I am available to answer those. So the last talk for me is to talk about the internal derangements, right? So covering up anything and everything in knee is a very tougher thing. So what I'm trying to focus on in this session is on the meniscus and cruciate pathologies, which are the most common ones, right? So if I talk about meniscus, right, we have understood that we have to see five structures when we talked about the anatomy, that is anterior horn, posterior horn, body, and both the roots, right? So all of you are on the same page that we talk about five structures. So now what I'm going to tell you more in detail about meniscus is how a meniscus is formed, how are the tears oriented, how do you decide what tear and their complications, and how do we decide onto the management. So let's start with the ultrastructure. This is very important, right? So every meniscus, so we will do this exercise in this entire session. I want all of you to put your hand like this, right? So you form a C with your hand. I want really. So now all of you are doing with me, I believe, is that a meniscus fibers which are running along the length of the meniscus like these, those are your circumferential fibers, and some fibers are running from inside to outside, inside to outside, inside to outside. These are your radial fibers. So I really want all of you to do this with me. Circumferential fibers, radial fibers, right? So we have two kinds of fibers. Now you can see these circumferential fibers are blue rods which are running along the meniscus, and they are mainly in the peripheral third. You can see in this image. Then your radial fibers which are running from inside to outside. These are predominantly in the inner two thirds and they provide more of the structural rigidity. So, what is the role of meniscus? You are standing, you're putting load on your knee, the load goes to the radial fibers convert the load to the circumferential fibers, and the circumferential fibers, because they are running along the meniscus, they take it up to the roots, and the roots give it to tibia. So, body handles everything safely, right? So, this is the normal mechanism, but if you have injury at any level, the transfer becomes incomplete and you start to injure your knee more. So now what do we call something as meniscal signal, or what is not a normal in meniscus? So if you remember, I showed you the normal meniscus, which was looking dark on all these sequences. So darkness is our friend, right? By this session, I think you would have realized that darkness is my friend. I sit in a dark room, I see all the dark structures which are normal. Whenever I see some bright light, I'm like, what is going on, right? So darkness is a friend. Similarly, so you need to grade the so you if you start to see signal within the meniscus, that's abnormal, right? But that's just a signal. So signal means if it is round signal, grade 1. If it is linear signal, grade 2. But if the signal is reaching up to the articular surface, it's a grade 3 signal, which is tear. So do not say grade 1 tear, grade 2 tear, grade 3 tear. These grades are only for signals and not for tears, right? So uh, if you want to say signal, say grade 3 signal. But ideally, when you see grade 3 signal, use the word tear. Otherwise, do not. Right? You forget anything from knee session, you cannot forget this. Right? I just want really this to be implemented. So show you this normal, all dark. You see some abnormality globular, but not reaching up to the articular surface. So this lower black band, upper black band, and central back areas are maintained. So this is just a grade 1 signal. Then you see this linear signal not reaching up to the articular surface. So this is a grade 2 signal, and this is actually the vascular pedicle which comes in and supplies the blood supply to the meniscus. Now if we start to see signal which is reaching up to the articular surface, it will become a grade 3 signal or a tear. So let's call it tear. Now, how do you think how many types of tears can be? So again, hands up. So you can cut the meniscus like this, or you can cut the meniscus like this. Any structure, if I believe this is the meniscus, I can either cut it like this or I can either cut it like this. There are just two simple ways to cut a meniscus, right? So something which cuts it from top to bottom, or something which cuts it from side to side. Simple. So similarly, vertical tears or horizontal tears. No, but life cannot be that simple. Huh? That then we can then anybody can say what. So we have to be smarter. So when it is cutting vertically, it can be of two types: longitudinal and radial. And this is very important to understand. So all the hands up again. You remember these were the circumferential fibers. So if this my vertical cut is going along the meniscus like this, cutting the meniscus like this, along the fibers, then this is a longitudinal tear. But if the cut is again vertical only, but going from inside to outside, then it is a radial tear. So this is very simple difference. If you know two fibers, you know the cut, and it becomes very simple. So let's imagine we have the cut the meniscus. So if we cut the meniscus like this, what tear is it? I just believe everybody said horizontal tear because I'm cutting like this. But then I have a vertical tear which is cutting the meniscus again from inside to outside. What tear is it? Radial tear. But if it is cutting the meniscus along the length of the meniscus, then it is what tear? This is the longitudinal tear. I really want all of you to understand this because this is something which makes your life very easy when you start to see tears. So now let's start to see the tears. So you see a signal which is cutting the meniscus into a upper half and a lower half and going like this. What do you think? What type of tear this is? So it is reaching up to the articular surface. To be sure on this, it is not sure. So reaching up to the articular surface. So first of all, it is a tear, and then it is cutting the meniscus into two halves, the upper and lower half. So what do you think? Upper and lower half. What do you think is this? This is a horizontal tear, right? This one is simple. Then simply cutting like this horizontally. Now we see another tear. So this is tear which is like vertical. It is coming from top to bottom. Let me see on other images, top to bottom, reaching up to the inferior articular surface. Again, in the other section also, top to bottom, reaching up to the inferior articular surface. Top to bottom. Now I've showed you three sections, right? In which, along which fibers? So it is cutting the meniscus somewhere in the posterior horn, and it is going like this along the fibers. Is it agreeable? It is going along the fibers. So if it is going along the fibers, what should it be? Vertical, which is along the fibers. It is a longitudinal tear. It is going along the fibers, right? Now I'll show you another case. You need to tell me what tear it is. So again, vertical signal top to bottom going along the fibers. Is it agreeable going along the fibers? So normal meniscus signal comes in going along the fibers, along the fibers, along the fibers. What tear is it? Longitudinal tear. What do you understand over here extra? If you try to see this bit, this is going into this bit ligament over here, into this ligament over here. So with respect to the posterior cruciate ligament, you have two ligaments. That is your posterior ligament and your anterior. So anterior one is your Humphreys and posterior one is your Risberg. So this is your Risberg ligament over here along which the tear is extending. So Risberg, and then it is the Risberg ligament attachment. So what happens? Normally the Risberg ligament attaches to your lateral meniscus, but with the injury, there is friction and there is a sudden traction. So the Risberg ligament, which is attaching till here, just rips off. So that's why this is also called as Risberg lip. So basically nothing exceptionally great. It is a longitudinal tear only, which is between the Risberg ligament and the posterior horn lateral meniscus, and it is that's why it has a name called as Risberg rip. So Risberg rip is just at the junction of posterior horn lateral meniscus and Risberg ligament. So this is your Risberg rip. Now again another fluid signal which we see vertically oriented. We all are on the same page? Vertical. Now let's see whether it's going along the meniscus or against. So if something is against, it will go from here to here, right? Inner to outer. This is going along. But do you realize that it is posterior to the posterior horn signal? This is posterior horn. There is signal and there is, I told you, the things which lie posterior to the posterior horn are your posterior medial capsule. So this is at the junction of capsule and meniscus. So junction of capsule and meniscus. So again, basically this is a longitudinal tear, But because it is at the junction of capsule and medial meniscus, it is called as ramp lesion. So this is a ramp tear, which is also called as meniscocapsular separation. So just to see another example, right? So now you see normal meniscus. Now you see a signal, and then it ends. So from inner, outer, do you think it is going against the meniscus or along the fibers? So this signal, if I show it to you on axials, signal from inner going towards outer. So this is not going along the meniscus like we saw. It's going against the meniscus. So this is your classic radial tear. So this is what I really want you to remember. Axials might be so helpful that you see the radial tear so well, but this is not the lucky situation all the time. So what you need to identify when you see on these images, it is going in from inside to outside, right? It is not going along the meniscus is the key to the situation to understand. So this is your radial tear. It is most common at the anterior horn hyphen body junction of the lateral meniscus. Then let's see another case. So do you think you want to call this as a tear on this image? No, it's not reaching up to the articular surface, right? Again, I see some signal not reaching up to the articular surface. And then you see the meniscus is not seen only. Meniscus has gone missing. Where are you, meniscus? So you see something is missing. So this is basically missing at the root attachment. So this is your root tear, which is a type of radial tear. So if you imagine at the root from inside to outside, you do not see anything. So a full thickness radial tear at the root is called as a root tear. Nothing but a root tear, right? Now we have become bonds. We know longitudinal, we know horizontal, and we know radial tears. So do you think life is simplified? No. Now you need to understand the complications. So because anything, so if you have a this longitudinal tear, then that can flip inside and become a bucket. You have a horizontal tear, it can give rise to flaps. You have a radial tear, it can become widened and become a parrot beak tear. So let me just try to show you a few examples and how do you understand those. Right, so this is your meniscus. I've tried to put all the images on one page. Anterior horn root, anterior horn body. Body, can you see the body looks pretty small? Normally, the body is like well seen, and you see an additional thing which is lying above. So, this is a tear with a flap which is lying in the superior gutter. So, whenever you have horizontal tears, what happens? This flap or this fragment can flip up or flip down. So, based on this, this is called as a flipped up and flipped down sign as well, or a thumbs up and a thumbs down sign as well. So just to show you another example, this is smaller body. This is the tear lying over here. Again, on this side, this is the smaller body and the tear lying on here. That's why I always told you to have to look at the size. That's why I was showing you the size of the medial meniscus. So this is nothing but your flap tears, which most commonly go to the gutters, but they can go anywhere else. So let's see what anywhere else means. So body lateral meniscus. Now do you remember the body of anterior and posterior horn should be same in size. Posterior horn is pretty small. Isn't that weird? So let's find out. Oh, there is something which is lying beneath and posterior to it. So see here, this is missing and this is lying over here. So this has got flipped over there only. So this is your flap tear of the posterior horn, lateral meniscus where the flap is lying. Then this is another example. You have a horizontal tear over here and you are tracing body, anterior horn, posterior horn, but size wise everything looks okay. Although we are not able to see the body entirely, which we'll see on the coronal, but as I go towards the intercondylar region, I see some extra thing lying over here. Some extra thing lying over here. So this is your, when you start to see something extra in the intercondylar region, that is your bucket handle tear. And this extra thing along with the PCL gives you a double PCL sign. And these two anterior horns because of the bucket are called as the double delta sign. So let's see here, the body looks pretty small, right? And you see some extra thing lying in the intercondylar region. So this is your bucket handle tear. So whenever you find something small, look for flaps or look for a bucket. So what happens with the longitudinal tear? This inner fragment becomes free and it flips inside in the intercondylar region, which gives us the extra piece in the intercondylar region, which is called as a bucket handle tear. And as I told you, it gives an appearance of a double PCL and a double delta. So two anterior horns and two posterior cruciate ligaments gives the name double PCL and a double delta sign. Now, can you see this tear extending from inside to outside, but pretty wide, right? So that's what is called as parrot beak tear. One radial tear keeps on dividing the meniscus. It becomes giant, and it is called as a parrot beak tear. Now, these are simple rules of meniscus which we learned, but meniscus is not going to follow all the rules all the time. So sometimes the signal was horizontal and it became longitudinal. So that is your oblique tear. It did not follow the path. It started as horizontal, became longitudinal. So that becomes an oblique tear. And sometimes signal was longitudinal, up, down, horizontal, all mixed. You are not sure what tear it is, then you call it a complex tear. Lastly, there is another thing which is called as discoid lateral meniscus. I've seen a few cases of discoid medial, not very common. I think I've seen two only till now. So that's pretty uncommon. Discoid lateral meniscus means the meniscus is very big in size. It's a congenital thing and it's filling the entire cavity. So here is your lateral compartment. From here till here, you have the body of the lateral meniscus. In this case, it shows a little bit degeneration as well in the anterior half, right? So that's your discoid lateral meniscus. How do you decide the management of the meniscus? So you normally your peripheral one third of the meniscus. So we divide the meniscus into three zones: peripheral, mid, and inner third, right? So the peripheral third of the zone has a good blood supply. That's why I've marked it as red. So anything which happens over here, so most likely the longitudinal tears or the ramp or the Risberg rib, they if you repair because of vascularity, they heal well. Similarly, the inner one third is avascular zone, no blood supply at all. So if you try to do a repair over there, it's going to not work. So you need to debride any tear over here. So mostly radial tears with the radial fibers over here, right? And then there is a pink zone which has some blood supply, not as good as the red zone, but you can still try to repair this zone. So based on the vascular supply, you can decide the management. And if you have complex tears, then the management differs, and but it's most often surgical, right? So you need to take care of this. So to conclude meniscus, what is most important is to identify that what is the meniscal tear. You would have some variants which I could not cover over here. So if you pick up a variant, you should not confuse it with a tear. But overall, what is most important, you know the ultrastructure, you know which tear and what complication is it resulting in. From there, we move on to the cruciates. Again, we need to understand the normal appearance, which we did with anatomy. Then we'll see how they get injured and what all injuries can be associated with them. So starting with the cruciates, you have an anterior cruciate ligament, which is actually having two bundles. That's why this is again another fellow whom you make do funny things. So you put your fingers in your pocket. So your cruciate ligament extends from the lateral femoral condyle to the anterior tibial plateau. The position of the two bundles are decided based on its tibial attachment. So the one which is attaching anterior is your anteromedial bundle. The one which is attaching posterior is your posterolateral bundle. So this is your based on your tibial attachment. This we discussed that this increased signal should not be called sprain. Just reiterating my point. Moving on to the ACL injuries. So just look at this video. See, the knee got into a twisting injury. And what happens when the knee goes into this twisting injury with the twist? The stretch on the ACL increases and it gets injured. And can you see the bone femur going rotating? So this anterior femur impacts again the posterior tibia. So anterior lateral femur impacts against the posterior lateral tibia, and there can be some impaction on the posterior medial tibia as well. So once you're imaging the cruciate, what you need to see is you need to see the cruciate in ligament in itself. So first of all, we are trying to look for cruciate ligament, whether it's injured or not. If it's injured, is it a partial thickness injury or it's a full thickness injury? And also where? Is it at proximal third, femoral attachment, mid substance, or a distal attachment? But you need to see the associated injuries as well. They are very important. So if you treat only this and you leave this, you are going to have a knee which is going to have recurrent instability, and the knee is going to be problematic to you also, which depends upon the mechanism and force. So management is going to change. Sorry. So the management is going to change if you pick up the associated injuries. So let's see this anterior cruciate ligament. So here is the ligament and it is completely torn, and there is a buccal ligament over here as well. So now it might be really difficult for us to understand on the sagittal images where exactly it is torn, but there is a lot of edema and this is buckling of the ligament. So we think that there is an ACL injury. So let's try to trace it on our axial. So you see ACL over here. I'm moving towards the femoral attachment, and as I move towards the femoral attachment, I do not see a significant ligament. I told you it should be seen as black and robust. It is nothing which we see over here. So it is nothing which we see from here. Proximal third completely gone. Femoral attachment, barely this one fiber over here, but nothing major. So it's predominantly a femoral attachment and a proximal third injury. This is how normally you should see. So this is a normal comparison. So it should be seen dark black. So on your sagittals, you were not pretty sure where the injury is, but your axials really help you. So that's why use your axials. Similarly, let's try to see on the coronals, we trace it, and here you see the disruption, and here you see barely few fibers. So it's basically a proximal third or a femoral attachment injury. Similarly, this is another proximal third injury where you see a fluid cleft over here in the proximal third, or in this case, where you see fibers are torn in the mid substance. So you need to see it on all the three planes to be sure where the location is. So this is, we are looking at the ACLs, right? We know that this is torn. These are kind of full thickness injuries where almost all the fibers are gone. If barely one or two fibers are left, it doesn't make a difference. It is going to be treated like a full thickness tear only. Then in younger people, you might see very often a tibial attachment osseous avulsion at the ACL attachment. So ACL, it is attaching over here. Because of the force of injury, twisting injury, the bone only comes off. So you need to give them a size of what bone and how much up it has come from the rest of the tibia. So that will give them an idea that how bad the injury is. So this is in young people, tibial attachment osseous avulsion. Now, this patient came to us again. Usually, they have a history of trauma. So, if there is no history of trauma and you see full thickness ACL, either the history is wrong or you're reading the scan wrong, right? That's not possible. So, if you see twisting injury, which was 1 week back, you see the signal here. I would have thought this is increased signal, but that should be normal. But I see increased signal over here also. That's very bothersome. But the ligament is seen through and through. So there is something wrong, I know. But what is wrong, I'm not sure, right? So let me see on my actions, which are really my best friends. So I see these fibers over here. When I become here, the fibers become thinner. The inner fibers are not that discrete. Again, I see some altered signal over here. Still, I'm tracing it, not really bad signal over here. But can you see now, suddenly the inner signal is not seen at all only, right? The inner signal is bright and this femoral attachment is seen again. So femoral attachment, then you see fluid signal and outer fiber signal. Fluid signal, outer fibers are preserved. Fluid signal and outer fibers. And here you see the outer fibers well as it goes towards the tibial attachment. So only these. This is a partial thickness injury or a single bundle injury, which was the anteromedial bundle, right? So axials will help you trace the fibers and help you pick up the single bundle injuries better. So how do we understand an ACL? We need to look for the orientation that it is going along the Blumensatz's line. It should have a normal signal, and we should be able to figure out that there is not a single bundle injury. However, in a torn ACL, you will lose the orientation, you will see discontinuity, and like in our first case, you might see empty femoral notch sign. Now, again, a patient with a history of pain for 1 year. 1 year back, he had some trauma. What do you think this is? Although trauma history is confusing, but if you see, you can see these fibers in here. Can you see? This is called a celery stalk appearance. So you have this celery stalk appearance with ganglion cystic changes with lot of edema in the ligament. So this is called as your mucoid ACL. Once you start to see, you need to remember this image in your mind, right? Once you start to see bright signal but thin fibers within the bright signal, that is nothing but your mucoid ACL. Some situations can be confusing when there might be a tear superimposed on mucoid ACL, but right now I'm not going into that. But what you need to remember that this is your celery stalk appearance. So to sum up, this is your normal ACL, this is your torn ACL, and this is your mucoid ACL, right? You need to understand the difference of the three. So now if a clinician tries to see normal knee, he's trying to do a anterior draws or a Lachman's test. He's not able to move anything, but can you hear him? See how aggressively he is able to move the knee. So he clinically knows that there is an ACL injury. Then why is he sending for me to see? I can tell him where the injury is, but that also is not going to make that much of a difference in the management. What he is sending it across to me is to find out the associated injuries and to find out false negatives, that sometimes there is, he knows that there has to be an injury because of the history of the patient, but when he tries to do this movement it doesn't go that forward. Why? Because the ligament has fallen and buckled down, or there is a bucket handle tear, or there is so much of muscle spasm and pain and he is not able to test, right? So we need to understand the associated injuries, and these we know we can figure out. We can figure out a buckled ligament like we saw in the first case, or bucket handle tear like we saw with the meniscus. So we'll be able to tell him how bad is the ACL. But most importantly, we need to tell him the associated injuries, right? So if there is injury to the bone, if there is injury to the posterior lateral or the posterior medial corner. If I talk about bones, what is most important is, as I told you, anterior lateral femur, posterior lateral tibia. So when these two marrow edemas you see, you are pretty sure that there is going to be an ACL injury. So nobody forgets this. Anterior lateral femur, posterior lateral tibia. And in addition, you might also see posterior medial tibia. So if you see these marrow edema patterns, you know you're dealing with a case of ACL injury. Sometimes you see marrow edema in the anterior lateral tibia. That's a very important clue. You look carefully and you see a bone chip which has come off. So this is called as your Seagon's fracture. It has a very high association with ACL. So it has 75 to 100% association with ACL injuries. So if you see the Segons, you are very sure that there is going to be an underlying ACL injury. So look for marrow edema in the anterior lateral tibia and then try to figure out if it is a Segons fracture. So these are the bony areas which you need to look carefully for associated injuries. Then you have the posterior lateral corner. So what all comes in posterior lateral corner? What we read and understood in the anatomy. So we need to look for injuries for any of these. So in this case, can you see this lateral meniscus is torn, popliteus is torn, here fibular styloid process is torn, and here you have FCL and popliteus injury. So you need to look for all the structures. You know what is your posterior lateral corners if you're finding any injury in any of those. Why are we doing so? If it is a very high grade injury to these structures, they need to repair these as well along with the ACL. Why? Because if these are not repaired, then there might be laxity and patient might ultimately land up into osteoarthritis if not treated for a longer period. Similarly, you need to look for posterior medial corner. What are our structures in the posterior medial corner? You all know by now. So your, in this case, you can see your MCL injury at the femoral attachment. Here you see posterior horn medial meniscus and posterior medial capsule also look injured. So if you see this, it is called as O'Donoghue triad, and you need to carefully look for these injuries. Why are we doing so? Because if we miss, they are not treated and they land up into instability, and ACL graft may also re-tear. Now, just quickly touching upon the PCL, you know how beautifully PCL was seen through and through a robust bundle with this anterior ligament is Humphrey, posterior is Risberg. H comes first, so Humphrey is anterior. So in this case, can you see the few fibers are intact, but anterior fibers are torn. So this is a partial thickness tear. In this case, here the tibial attachment has come off. So a younger patient like ACL avulsion, you can have PCL avulsions, and you see usually a dashboard marrow edema or an anterior tibial marrow edema, which is a clue not very often seen. To tell you guys, PCL injuries are very commonly missed because patient just has little vague pain posteriorly and he ignores and keeps on going on with it, right? But if it is a severe injury, he would come. It's your responsibility to trace the PCL in entirety. So to sum up, ACL, you look for classic marrow edema patterns and never skip associated injuries. So marrow edema patterns will help you pick ACL injury in doubt. However, associated injuries will help do the management because they know what to treat. Posterior cruciate ligament, it's your responsibility to trace it on axial sagittals at least, right? Because history is very minimal in most cases, so it might be missed. Bone marrow edema patterns is a clue but might not always be available for you. Thank you so much for your patient listening.